God, I sound like the nun. Dr. Puri today is going to be talking about acute arterial occlusion of the lower extremity. Dr. Puri assures me that he grew up and was educated in India, which I find hard to believe. No matter what Dr. Ivaturi tells me, he's not from Virginia. And then has been in our program and is expected to graduate, and then is going on to an MIS fellowship in Jacksonville. Dr. Puri, welcome.
Thank you, Dr. Srenik. That was rather pleasant. I'm going to talk about acute arterial occlusion in the lower extremity today. And that's my first disclaimer. I wish I had some financial relationships to talk about, but I don't. This is just a broad overview of the talk. The bulk of the talk is going to be on management of the acute lower extremity ischemia, and then I'm going to touch upon thrombosed popliteal aneurysms, reperfusion compartment syndromes, and phlegmasia. At the outset, I think it's worth giving credit to our forefathers who have gotten us here. Dr. John Hunter is known as the father of vascular surgery. Hunter's erectors canal is known to everyone. This is the most common site of occlusion of the SFA. Dr. Kruvahe is the first person who said that gangrene occurred due to occlusion of the arteries. Dr. Lariche talked about aortic occlusion and aortic occlusion causing impotence and buttock claudication. The contribution of Dr. Howell and J. McLean is very important. They are credited with discovering heparin, which we obviously use not just in vascular surgery, but has numerous uses in medicine in general. Dr. Howell is also credited with the Howell-Jolly bodies, which we see in peripheral blood smear after a patient has had a splenectomy. Dr. Palmas may be known to some folks in the audience today. He was a radiologist at our institution, and he is the first person to develop balloon expandable stents, which revolutionized not just peripheral vascular surgery, but management of acute coronary syndrome. Interestingly, Dr. Palma is a big Porsche enthusiast, and he's got 17 Porsches in his collection. And I know, he just beat you, bailed, Dr. Srenik. Dr. Fogarty, lastly but not the least, he devised the balloon embolectomy catheter, which you can see him holding in one hand and the vine, obviously, in the more important right hand. That's correct, as a medical student. And that tiny balloon in his hand has 67 patents. I don't know how, but it does. And he has numerous vineyards that he owns. So for young medical students and young residents, the moral of the story is go out there, discover something, get a patent. It'll be worth your time. So coming to acute lower extremity ischemia, there are about 1.5 cases per 10,000 per year. About 10 to 15% of these patients will require an amputation, usually above knee amputation. 15 to 20% of these patients will die within the first year due to comorbidities, usually cardiovascular disease. And this is just a picture showing the broad classification of acute arterial occlusions, embolic, thrombotic, and trauma. I will not touch upon trauma a lot because that in itself is a big topic. As far as embolic occlusion goes, 60 to 70% of these patients will have cardiovascular disease. And with that, I'm going to talk about a patient that I had taken care of a few months ago. At around 8:30 or 9 p.m. at night, we get a call from the ER. They were trying to find a medicine resident, and they called us by mistake. So we go down and find out what's going on. They have a fax report from Seguin on a patient who has a duplex, and there was no flow in the right leg from femoral down to his foot. And they were looking around trying to find a medicine resident. I'm not sure why, but they were. So we called Seguin and had the patient transferred to us. So RW was a 77-year-old African-American male with 3-day history of pain and decreased sensation in the right lower extremity. He's a vasculopath with all those medical problems, coronary artery disease, AAA, CHF, hypertension, peripheral arterial disease, AFib, and a pacemaker. His past surgical history was relevant because we fixed his AAA in 2005 with a bifurcated aortobiliac graft. And then in 2011, he underwent bilateral femoral aneurysm repairs with Dacron graft and also had an endovascular repair of the right internal iliac artery aneurysm. He was a 40-pack-year smoker, and his medications are listed there. He was on Coumadin for his AFib, but of note, the Coumadin was stopped about 2 months ago because there was some concern that he was depressed and he was trying to kill himself. So he came to us with that history. And moving on to embolic occlusions, embolic means to plug. They usually lodge at bifurcations because that is where the vessels are narrower compared to the rest of the tract. They do have worse outcomes. There is a phenomenon of secondary thrombus, which basically implies that once a thrombus is present in the artery, the blood proximal and distal to the vessel stagnates, and the thrombus enlarges and causes more ischemic damage. The most common cause, as we know, is atrial fibrillation, and the second most common cause after that are mural thrombi after an acute myocardial infarction. And other causes include endocarditis, atrial myxoma, especially in young patients, thromboembolism, and aortic mural emboli. Some patients with DVT may get acute arterial occlusion due to patent foramen ovale, and when this happens, it's called a paradoxical embolus. And this is a cartoon showing the causes of peripheral thromboembolism. As you can see, the most common cause is due to iliac and femoral system, and then the second most common is aortoiliac. This is a patient who has blue toe syndrome. Blue toe syndrome is due to microemboli, usually originating in the aortic thrombi, and when they get showered to the periphery, the patients usually present like this, and when they do, you have to look for a more proximal source. The second common cause of acute arterial occlusion is thrombosis, and the most common cause of this is progressive atherosclerosis. The process of atherosclerosis in the peripheral vessels is actually similar to that, what happens in the coronary arteries. You usually have a small atherosclerotic lesion which progresses to a plaque, and there's deposition of lipid and calcium, and the plaque enlarges. Since this process takes time, there is enough time for collaterals to develop, and these collaterals actually dictate how severe the subsequent ischemic insult is going to be. Sometimes decrease in cardiac output may also cause acute limb ischemia, so a patient who has peripheral arterial disease and they undergo severe MI and have decreased cardiac output, that may lead to acute limb ischemia. Other hypercoagulable states, antiphospholipid syndrome, heparin-induced thrombocytopenia, and aortic dissections are all causes of thrombosis as well. And the list is long, but I'll skip and go fast. Vasospasm, vasopressor ducts, compartment syndrome, phlegmasia, which I'll talk about later. Trauma, not just penetrating, but blunt trauma can also cause acute occlusions due to intimal flaps and subsequent thrombosis. And bypass graft occlusions are another cause of thrombotic occlusions. Usually bypass graft occlusions early on are due to technical factors and need a revisit to the operating room. Late graft occlusions are usually due to intimal hyperplasia at the proximal and distal ends. But the most common cause of graft occlusion overall is progression of distal disease, distal to the anastomosis. Evaluation of a patient with acute limb ischemia is important without saying, and it relies heavily on your clinical judgment and your history and physical exam. A patient who presents with such needs a very good history detailing the severity of the symptoms, the duration the symptoms have been going on, and the level of dysfunction. So if the patient has buttock claudication, thigh claudication, calf claudication, so on and so forth. Again, majority of these patients will have a history of cardiovascular disease. Thrombotic patients may have a history of peripheral arterial disease. Past surgical history and history of endovascular intervention is again important because they may give a clue as to where the problem lies. Family history, smoking history, etc. is also important. The 6 Ps are known to everyone. Pain and paresthesias are the usual early symptoms of acute arterial occlusion. When pain proceeds and develops, and patient develops loss of sensation, that means that the ischemia is progressing. Pallor is the early symptom, early sign. Pallor usually goes on to progress to mottling, and when this mottling becomes non-blanching, then gangrene is inevitable. Pulselessness, poikilothermia, and paralysis are all late signs of acute limb ischemia. When paralysis is setting in, light touch and proprioception is usually the first sign to go. Now, obviously, it goes without saying that the vascular exam on these patients is imperative, especially of the uninvolved extremity. Patients who have a normal opposite extremity are most likely suffering from an embolic occlusion. So they will have a normal exam or a near normal exam on the opposite side, and obviously an abnormal exam on the affected side. Whereas patients who have thrombotic occlusions and have a known history of peripheral arterial disease will have an abnormal exam on both the sides. Obviously, the side that is affected is going to be worse than the other one. So coming back to our patient, we had him transferred from Seguin. Took us about 2.5 hours for him to get there. He was neurovascularly intact. He did complain of pain in the right lower extremity. Excuse me, there was no sensation or motor below the knee on the right side. He had a history of AFib and his rhythm was irregular. For his vascular exam, on the left side he had a palpable femoral, a monophasic popliteal artery signal and a monophasic posterior tibial, but the DP was absent, again signifying that he already had some PAD going on. On the right side that was affected, the femoral was monophasic, there was absent popliteal, and there was no dorsalis pedis or posterior tibial that was present. Now coming to the stages of acute limb ischemia, it's divided into 3 stages. Stage 1 is when the limb is completely viable. There's no sensory loss, there's no motor loss, and you have Doppler signals both in the arteries and the veins. Stage 2 is subdivided, 2A and 2B. 2A, the limb is marginally threatened, but salvageable. There may be some loss of sensation on the toes, but again, the patient is still motor intact. Doppler signals are often present. Stage 2B signifies a more severe degree of ischemia. The limb at this point is immediately threatened and salvageable, but with immediate revascularization. The sensory loss is more prominent, extending more proximally from the toes, and there may be mild to moderate muscle weakness. The Doppler signals usually at this point will become inaudible, even though you may get a faint Doppler signal in the venous system. And stage 3 is the last stage of ischemia, where there is irreversible damage, major tissue loss is expected, and permanent nerve damage is inevitable. Now on these patients, the patients will have an insensate and aesthetic extremity. There will be profound paralysis and rigors of the muscle, mainly because they are depleted of ATP and not capable of relaxing, and both the arterial and venous Doppler signals would be lost. The next step is usually some sort of imaging, and I would like to point out, though, before we go to that acute limb ischemia is mainly a clinical diagnosis. Given after a thorough history and physical, you will have a fair idea where the problem is and what needs to be done. Imaging can be helpful. The most commonly performed and the most rapidly readable and reproducible is probably a CT angiogram. This is a CT angiogram of a patient, again, we took care of a few months ago. And if you see this, you have some contrast in the aorta over here, but infrarenal, there is nothing.
Ruchir?
Yes, sir.
You'll use a computer pointer that people in Harlem use.
Oh, okay. So there's flow over here, but infrarenally there's no flow and it's thrombosed. And CT angiogram may influence your decision making. Even with surgical revascularization of acute limb ischemia, the principles are similar to other elective vascular cases. You need an inflow, you need outflow, and you need a conduit. If on the CT angiogram there is no distal target outflow, then probably surgical revascularization in these patients may not work. Some other imaging modalities are angiography and MRA. Angiography is usually utilized intraoperatively. MRA may be used in the patients who don't have 2B ischemia, where the limb is not an acute threat, and patients who cannot get IV contrast for any reason. That is, they may have allergies or they may have kidney dysfunction. And in both these patients, you can see long segment occlusions of the SFA, extensive collateralization, and more proximal disease in both the patients. Some other imaging modalities are duplex and getting non-invasives and doing an echocardiogram. And again, just to re-emphasize that this is mainly a clinical diagnosis and we should not wait around to get these studies. So this is the CT angiogram of our patient. By the time we brought him in, by the time the OR, this is around midnight when this is happening. So by the time he came in and given his past history of multiple stents and his aorta bifem, we got a CT angiogram. So this is his distal aorta, where you can see a tiny amount of contrast and a big thrombus. And if you go lower down, you see flow of contrast in the left common iliac, but on the right side, there's an occlusion. And this is the end of his right iliac artery stent that was placed in 2011. And going further down, again, you can see flow in the external iliac, and then the femoral and profunda on the left, but really nothing on the right, maybe a sliver of contrast in the profunda on the right side. So, coming to management of acute limb ischemia, all these patients need to be obviously admitted in the ICU setting and need to be placed on anticoagulation with heparin, again to prevent the secondary thrombus that I talked about. They need oxygenation to optimize oxygen delivery to the peripheral tissues, hydration and pain control. And the subsequent management depends on what stage of ischemia the patient is in. Stage 1, where the limb is viable and not threatened, there's no sensory motor loss, and you have Doppler signals, you place them on anticoagulation and plan on an endovascular intervention to find where the problem is and how to fix it. Class 3 ischemia, where the limb is already damaged, there's loss of sensory motor, there's paralysis, there's no signal, they again need to be placed on anticoagulation to prevent further extension of the thrombus, but these patients should be offered an amputation once the limb is demarcated. Where once the limb is already dead, there is no benefit to trying to revascularize them. We can give them a bad reperfusion syndrome, potentially kill them, but we probably won't save the extremity, which is dead anyway. Now, the bulk of this talk is actually on how to treat class 2 ischemia, or the patients whose limbs are threatened. Again, 2B, they are marginally threatened, and 2A, are marginally threatened, and 2B, where they are immediately threatened but salvageable. And the therapy relies on mainly two techniques, endovascular and open surgical. Endovascular techniques are either a percutaneous mechanical thrombectomy or a catheter-directed thrombolysis, or just thrombolysis. And operative interventions include a balloon catheter or Fogarty embolectomy, a bypass, or an endarterectomy. Now, since the last decade or two, there have been a whole slew of devices used for thrombectomies, and this list is not exhaustive, and there are many more that can be put on this list. And I would not dwell into the devices too much, but just touch upon the two that we use commonly. The first is the angiojet device, and this is the machine, and this is the catheter. This catheter goes in over a sheath where the thrombus is. These tiny holes, they squirt saline at high pressure and high velocity, and this creates a vacuum and negative pressure which sucks in the clot and removes it. Usually after a couple of passes of this catheter, an angiogram is done to see if the clot is removed or not, and typically patients are left with a catheter to drip a thrombolytic for 24 to 48 hours, come back, repeat arteriogram to see if the clot is completely lysed or not. The second device is a trellis device, and as you can see in this cartoon, it has got two balloons which traverse the clot. The device itself has multiple ports. These two green ports are for the balloon. The middle red port is where the lytic agent is dripped in, and this is a fourth aspiration port. And also, kind of same principle that we blow up the balloon, drip the lytic, and once this is done, do an arteriogram to see if it's lysed. And typically, these patients also get a thrombolytic for a few more hours. So, CDT or thrombolysis, the agents work by lysing plasminogen into plasmin, which then degrades the fibrin. It was first described by Dotter in 1974. The one that we use most commonly in our practice is alteplase. Again, it's administered over 24 to 48 hours, and after 24 and 48 hours, you get you get an arteriogram to see if the vessel is open. And usually IV or through the sheath, heparin is dripped to prevent a pericatheter thrombosis. There are multiple advantages of thrombolysis. Apart from lysing the clot, it opens collaterals and microcirculation. It avoids sudden reperfusion injury, which is always a concern with open revascularization. It reveals underlying stenoses and prevents endothelial damage from balloons. But while it's helpful, there are many contraindications. Established CVA or TIAs within the last 2 months, active bleeding diathesis, active GI bleed within the last 10 days, intracranial or spinal surgery or intracranial trauma within the last 3 months, and intracranial malignancy or metastases, just to name a few, are absolute contraindications to its use. And there are a couple of relative and minor contraindications where you have to weigh the risk and benefit of its use. This is a picture showing a balloon catheter embolectomy. These Fogarty balloons usually come in sizes 2 to 7 French, and they're placed in the vessel. The balloon is inflated and subsequently withdrawn by releasing pressure gently, and along with it usually comes the thrombus. Now, multiple passes of this Fogarty may be needed before the vessel is open, and once you have good back bleeding, an arteriogram is performed to ensure that the vessels are open and you have good flow. So now the question is, what do we use, thrombolysis or surgery, or both? There are a few trials looking and comparing both head-to-head. The first of these trials was the STILE trial. It included patients, it was conducted in many centers across US and Canada. It included patients 18 to 90 years of age who had acute limb ischemia or subacute limb ischemia within the past 6 months. But in this trial, the embolic occlusions were excluded. They randomized about 400 patients into surgery, TPA, and urokinase. About 1/3 of these patients had acute ischemia, that is with less than 14 days, and the rest had ischemia for a longer duration. And when you look at the results, a couple of things which stood out. So patients who underwent thrombolysis had a much higher incidence of ongoing or recurrent ischemia, almost double that of surgery. There was obviously a higher chance of having life-threatening hemorrhage and vascular complications in the thrombolytic group compared to the surgical group. And when you substratified acute, that is less than 14 days, to patients who had ischemia longer than 14 days, this was even more prominent. So ongoing recurrent ischemia, 38, 48 in the acute group, but 20 and 58, almost 60 in the chronic group. So suggesting that patients who have chronic ischemia did worse with thrombolysis compared to surgery. And the risk of major amputation, though, was higher with surgery when done acutely. And going on, they looked at the 6-month results, and if you see over here, the mortality, the death and amputation rate was higher with surgery if the ischemia was acute, but not so much if it was chronic or more than 14 days in duration. But they did note there was a 55% reduction in the planned revascularization procedure after thrombolysis. So a patient who was, let's say, deemed to have above knee amputation after thrombolysis ended up with a below knee amputation. So a couple of results from this trial were, again, patients who had acute limb ischemia did worse in terms of amputation and surgery, amputation and death if they were operated on. But patients who had chronic ischemia had better outcomes in terms of less recurrent ischemia when they had surgery. So essentially 14 days or less leaning towards thrombolysis and 14 days or more leaning towards surgery. The second trial, which was published a few years after the STILE trial, was the TOPUS trial. Again, multiple centers in US and Canada, and they included patients only with acute limb ischemia, that is less than 2 weeks. Now this 14-day figure of acute limb ischemia is kind of arbitrary. There's no real data behind it. So they had 4 arms, each had about 50 patients, and 3 of those arms had different concentrations of urokinase, so 2,000 international units, 4,000 and 6,000 for the first 4 hours. Then all these patients got 2,000 international units after 4 hours. And they found that recanalization rates were kind of similar in all the 3 urokinase arms. The complications, though, were least with the 4,000 international unit arm. And when they looked at surgery versus urokinase, the survival rates, the 12-month survival rates were kind of similar across the board in 2,000, 4,000, 6,000, and the surgical arms. And the amputation-free survival was actually better at 12 months in the 4,000 international unit arm versus the surgical arm. So both suggesting that within the first 14 days, probably thrombolysis is better than surgery. And this was a prospective study from United Kingdom, where 43 vascular surgeons and radiologists looked at their experience with just thrombolysis. About 1,000 patients, more than 1,100 episodes. Most of these patients had ischemia, which was acute. 75% was within less than a week. And about half of these patients had partial or complete neurosensory deficit. This is just showing the causes of death and complications. And again, if you go to this slide, if you look over here, as the neurosensory deficit worsens, obviously the outcomes and amputation-free survival worsens. So patients who had no neurosensory deficit had 80% amputation-free survival, whereas patients who had complete neurosensory deficit had a 56% amputation-free survival. They did not notice much difference between native and graft. And as far as occlusion goes, there was not a huge difference between thrombotic and embolic occlusions. And then they looked at a bunch of factors in all these patients which affected mortality and morbidity. So factors related to amputation-free survival was higher age, diabetes, higher Fontaine grade, and presence of a neurosensory deficit. Factors that increase the risk of death, obviously increasing age, ischemic heart disease, occlusion caused by an embolus, and women were found to have a higher mortality. And the risk of amputation was worsened if they had a male sex, had graft occlusions, had a higher Fontaine grade, and had thrombotic occlusions. So just to highlight the results once again, amputation-free survival, 80% with deficit and, without deficit and 56% with deficit. And there's no significant difference between arterial occlusions due to thrombus and due to emboli. And amputation-free survival was 91% after 6 successful intra-arterial lysis, compared to 40% with the occluded graft. And Vandenberg then combined all the 3 randomized control trials and few review articles. And the reason I included this was the STILE sub-analysis, which was published a few years after the original STILE trial, looked at bypass graft, and this shows that the limb salvage rate was higher with thrombolysis compared to surgery if the bypass graft was occluded. They also noted that no difference in surgery and thrombolysis in terms of mortality and amputation. The risk of major hemorrhage is obviously increased, but the subsequent intervention was less severe if they were thrombolized earlier. So this is probably, I guess, the most important slide of the talk. So when you're choosing thrombolysis versus surgery, which one to use and how? So patients who have a viable or marginally threatened limb, so that's stage 1 and 2A, thrombolysis is probably better, as evidenced by the STILE and TOPAZ trial. If the occlusion is recent, that is within 2 weeks, then they will have better outcomes, probably thrombolysis. Or if there's a thrombosis of the synthetic graft or occluded stent, again, thrombolysis would be preferable. Whereas surgery is better if patient is a stage 2B, that is, the limb is immediately threatened and they need immediate revascularization, or if the occlusion has been present for more than 2 weeks. Now this, in the surgical aspect, it may change because more and more people are using angiojet, even for stage 2B or immediately threatened limbs. But the angiojet device is not universally present, and everybody is not using it at present. So, but again, this might change as the years go by. So coming back to our patient, RW, he got the CTA. We took him to the operating room about 1 a.m. We did right femoral cut down. We did a thrombectomy of the aortoiliac, femoral, and popliteal arteries. After doing that, we shot an angiogram and noted that he had a stenosis of the right common iliac. So we placed a balloon expandable stent across the right common iliac, did 4 compartment fasciotomies. Our initial plan was to do a non-anatomic axillary to femoral bypass if we could not restore flow. But we were able to restore the flow. So while we explored the axillary artery, we did not actually do the bypass. And also in the OR, the anesthesiology team performed a transesophageal echocardiogram. His EF was less than 20%. So that was a further impetus to close things up and not waste too much time in the operating room. On the completion angiogram on the right side, his anterior tibial was occluded, but his posterior tibial was patent. His post-op course was relatively uneventful. He went home in about 2 weeks, fully sensory motor intact. He has since been seen in clinic and is actually doing better than expected. Coming down to the popliteal artery aneurysms, thrombosed popliteal aneurysms, as we know, they are the most common peripheral aneurysms. They are contralateral in about half the patients. About a third are associated with a triple A. So if you have somebody with a popliteal aneurysm, please look proximally, make sure aorta is okay. 30% of these will have an acute limb ischemia. 14% may have coexistent vein thrombosis, and both surgery and thrombolysis can be used. The principles are kind of similar to that about acute limb ischemia in general. Thrombolysis can be utilized if limb is not immediately threatened, or if there's no outflow distal target on a CT angiogram. Surgery, again, if the limb is threatened, if there is a distal target for a bypass, then a bypass should be performed. If there's no distal target for a bypass, then a thromboembolectomy should be performed by exposing the trifurcation. And a quick word about reperfusion syndrome. The consequences of reperfusion can be systemic and local. Local reperfusion, locally, once reperfusion occurs, you'll have tightening in a compartment syndrome, and systemically, you'll have the full-blown reperfusion syndrome. Once ischemia sets in, the muscles start getting irreversible damage in as early as 3 hours, and those are the time frame for some other structures. Ischemia leads to the cells dying, and the capillary permeability is increased, leading to leakage of plasma in the interstitial space. And once the limb is revascularized, a bunch of products are released from the dying cells, along with inflammatory mediators, including amino acids, lactate, lysozymes, myoglobin, so on and so forth. And there's a huge complement response, interleukin, leukotrienes, histamine. So every inflammatory agent that you can think of is released. And the myoglobin preferentially goes to the renal tubules and precipitates there, and that's the reason for trying to alkalize the urine, because at a pH of less than 5.6, the myoglobin precipitates in the kidneys and causes acute tubular necrosis. And alkalizing the urine prevents that. And so the management includes aggressive volume resuscitation, urine alkalization, getting serial CKs and urine myoglobin levels, and a fasciotomy. And since this reperfusion syndrome has a high mortality and is a big concern, there have been a lot of research into how to prevent it. And this is a paper from the BAMC people, Dr. Rasmussen's group. And they looked at, so surgically, you try to get them to the OR as soon as possible, because the longer the ischemia goes on, you'll have more reperfusion injury. Use of vascular shunts in patients who have acute limb ischemia, fasciotomies, limb cooling, and conditioning. And conditioning refers to not doing a full-blown surgical revascularization, but intermittently doing the revascularization over a few minutes. As for medical things that you can use to decrease the inflammatory response, you need hypertonic saline, maybe statin, and some ethyl pyruvate. Compartment syndrome is obviously a big concern after revascularization, both in trauma and non-trauma patients. And this essentially starts when the cells start dying and the capillaries become leaky. Once revascularization is done, there's more blood flow and the leakage gets worse. There's increased venous pressure, increased capillary pressure, increased compartment content, and this is a vicious cycle that just keeps going. Anterior compartment of the leg is the most commonly affected. Pain, paresthesias, and paresis are the early symptoms. Pain is probably the most early and sensitive clinical sign. Exacerbation of pain with passive motion is present. Indiscriminate use of analgesics is obviously to be condemned. And fasciotomy in the vascular patients who are revascularized should always be done. And non-vascular patients or in trauma patients, I think if you're suspecting that there may be a compartment syndrome or you're thinking about it, you should probably go ahead and do a fasciotomy. As far as the compartment pressures, I have never done a compartment pressure myself. Again, if I'm suspecting there's going to be compartment syndrome, I'm just going to do a fasciotomy. And lastly, a word about phlegmasia. Usually of two types, phlegmasia alba dolens, which is white, and cerula dolens, which is blue. This occurs when there's major pelvic vein thrombosis in the thigh or the pelvis in the femoroiliac system. There's pain, pitting edema, and blanching. There's progressively decreased venous return, leads to swelling and maybe cessation of arterial flow. 50 to 60% of these patients will have peripheral arterial disease. When there's acute limb ischemia due to phlegmasia, this is called phlegmasia cerula dolens. Venous gangrene may be present in 40 to 60% of the patients, and this is a patient with such, where you can see this blue leg compared to the opposite normal leg. It carries a high mortality. It's got a very high amputation rate. The risk factors are essentially those of hypercoagulability, including malignancy, heart failure, immobility, heparin-induced thrombocytopenia, antiphospholipid syndrome, and so forth. Duplex is a useful imaging modality, and the management includes aggressive fluid resuscitation, bed rest, elevation of the limb, and anticoagulation. thrombolysis of both the arterial and venous systems may be required. Fasciotomy is almost always needed. Thrombolysis can result in resolution of the thrombi in up to 90% of the patients. Most surgeons will go ahead and place an IVC filter after thrombolysis because once these thrombi enter the systemic circulation, they go to the lungs and cause a pulmonary embolism, which is suboptimal. With that, I'm going to end my talk. This is my second disclaimer, and I know what you guys are thinking, but this is not Dr. Serenik. And I'll be happy to take any questions. Thank you for your time.
So which one is you?
This one.
All
It
right.
matches my skin tone.
What about fasciotomy? If they're going to be taking their oral exams, do people really, on the vascular service, do they really measure compartment pressures, or you just go ahead? Is there a difference whether it's 1 hour, 2 hours?
So the longer the ischemia has been going on, probably the higher chance of compartment syndrome and that you want to do a fasciotomy. Again, I think when the patient comes in, it's important to take a good history and physical. I mean, if they tell you that I've been having this pain for 10 hours and the foot is pale and dead and insensate, at that point probably should not be revascularized. If it's a stage 2B where revascularization should be done, then the longer the ischemia has been present, the higher the chance they'll get a compartment syndrome. So fasciotomy should be done. As far as doing the compartment pressures, again, I have read about it, but I've never done a compartment pressure. And if I'm thinking that somebody needs a fasciotomy, I'll probably do it rather than take compartment pressure. So
There are complications associated with doing fasciotomies, though, and so
Absolutely.
it's not a complete
it's not a completely benign
innocuous
procedure.
procedure.
That's true.
I don't remember. There's a nerve that can be damaged.
Peroneal nerve.
Peroneal nerve. I don't want to let him go. Dr. Dent?
No comment. Good talk.
I thought I saw Dr. Pounds walk in. Ah, there she is. I'm sorry you were behind the big head of Dr. McHale.
2 weeks.
Any additions, deletions?
No, I mean, most of the time, you have to realize, we sort of de facto on the popliteal
Push the button.
expirations. On the popliteal expirations, we actually usually have at least partial fasciotomy, and so the decision then is to go on and do the anterior and lateral compartments. And it's usually a clinical one based on the amount of ischemia, the acuteness of it, and whatnot. We don't really measure compartment pressures. And then for the venous thrombolysis, just to clarify, again, catheter-directed thrombolysis, there are some new pharmacomechanical things that are out there that there's trellis, which is you take 2 balloons and it's got a little whip in between them. There's angiojet, which uses a power pulse technique where Venturi sort of pulses out TPA and then sucks it back in. There's ECOS, which has an ultrasonic component to it. But those all take time. And so if you really think someone is threatened, either arterial, and then venous, they usually walk a different path. The venous are usually malignancies when they come in with phlegmasia. All right, it's not really an arterial thing for the most part. But, time is of the essence. And I know it's not a very common procedure, but, a venous thrombectomy is very easily done through a femoral exploration. You take a little branch, you put it over the femoral artery for your AV fistula afterwards if you need to. But it's much easier to do that quickly than to try to put them through 24 hours or more of thrombolysis that may take, if your clot burden's very high, you may end up using a lot of TPA.
So we are more surgically aggressive with venous thrombosis.
I am more
in the
surgically
distant
aggressive.
past, it was assumed that the intima was just damaged, and any attempt to clear the clot was only going to result in recurrent thrombosis.
Well, if you look at it from a perspective that long-term venous issues, if you're just doing this for like someone who doesn't have phlegmasia, but the long-term venous issues are the post-thrombotic syndrome, and that's, if you think of it, it's like the government, obstruction and incompetence. If you have an obstructive process, which is up in the pelvic, the iliofemoral and the IVC, you've created a huge venous hypertension issue. There's not many valves up there you're really preserving. Whereas down in the femoral popliteal, you are preserving more of a valvular thing. All right, but to take somebody from obstructive to non-obstructive, even if there is intimal damage, you're still going to do them good in the long term. I mean, I just got back from the American Venous Forum, which is like 4 days of all venous compression, lysis, all that kind of stuff. And most people are getting much more aggressive. The problem is in the chest guidelines in 2008, they suggested thrombolysis for good risk patients. They actually took it out in 2012 and didn't really say much about it. So we're sort of like a little bit of conundrum, and there's some trials out there they're trying to do. But, you know, I would personally like to see people get more aggressive about venous thrombolysis.
If you see a patient with a post-phlebitic leg syndrome or have to take care of them, it prompts you to be more aggressive. It's really a debilitating problem for somebody.
Right. Which is what basically 80% of my practice is the long-term sequelae of venous thrombosis.
Any other? Yes, Dr. Abergili.
A good talk. It's a big talk. I'm disappointed you didn't throw the name of Alexis Carrel here, the father of surgery. I was hoping you sneak him down here. He was one of the laureates. You know, very few surgeons are
Next time, Dr.
Nobel Prize. Number two, how do you, this is a board question. You've been examined. A young woman, pregnant, second trimester, developed phlegmasia cerulodolens. How are you going to handle her? She's young. She does not have post-phlebitic syndrome. And you see it after pregnancy. She has varicose veins. She developed phlegmasia. How are you going to handle it?
Well, I think if you don't intervene, she's pregnant, and that's, I guess, a potential issue. But if you don't intervene and lyse her veins in the artery, then she's going to end up losing. I would lyse. I would do a thrombectomy and lyse her at the same time. Yeah.
That's all what you do? How are you going to keep the flow going in the vein? She's going to occlude.
Well, I'm going to do thrombolysis and put her on heparin.
That's it, to keep this is open. Anything else you're going to add to your thrombectomy? You remember this is a low system. It's not artery. It's not high flow to low flow. You're not bypassing the occluded segment. Have you heard of the AV fistula?
Yes.
That's what you add.
Okay.
What about that in the, still do that?
Fistula? Yeah. I mean, the guy I trained with in fellowship is a real big venous guy. So what we would do is we take a little branch of like the interlateral vein or one of the branches, or usually 5 off the saphenofemoral junction, and just take that over and hook it to the femoral artery. You wrap it in a PTFE sort of sheath so that it doesn't get aneurysmal, and then put big proline sutures that are loose. And so sometimes what you can do is when you go back to occlude it, you can either try endovascular techniques, or you could just go back and re-explore the groin, find the long stump of the proline, and tie that down since you're down over the fistula, and that's usually enough after you've had time to endothelialize.
Do we still use a Fogarty catheter for an embolectomy? You didn't really address that,
Yes,
just
yes.
as a lone procedure, or
Yes, we do.
for
All the
acute?
time. Yes, absolutely.
Is there a time period? Initially. All right, thank you very much.
Welcome, sir.